So now the discussion is open. Sheraz, I think you want to mention something, or?
All I can say is I've had it with EDOF. No, I don't think EDOF should be used as a terminology because it's too confusing. People have mixed mechanisms of action with performance. So because it provides intermediate vision, it's called EDOF. But the mechanism of action doesn't necessarily do what people think EDOF is doing. They also think it's forgiving, but it's not. I've removed a lot of so-called EDOF lenses and replaced them with trifocal lenses. Now, most people say, well, why would you do that? But they have complaints which are quite valid, and they're very much happy with the trifocal. 90% of my patients will have trifocal lenses. Whether they have cataract, whether they're 85 years old. The oldest I did was a 96-year-old optometrist.
So sorry to interrupt here. So just correct me. My understanding that your usual practice is trifocal.
90%.
90% of your practice, regardless whether it's post-refractive or virgin eyes.
I do at least 2 patients a week who've had previous laser eye surgery.
Can you just tell us about how often? Because I guess we are doing less. Dr. Muhammad would like just to come in. Maybe can we have a mic for Dr. Muhammad? So how happy your patients are, like, do you spend lots of time? If you are doing 90%, I guess you are doing plenty of cases. So
we do. We have
you need to do lots of pre-op counseling and post-op counseling. So tell us about that.
Okay. So we are an organization, and we are set up organizationally to deal with these patients. So a lot of the material is provided to them in advance or during the process before they see me. And I just go for the salient points. Firstly, they've got to be lucky enough to be suitable for surgery. So we underplay it. You may not be suitable. And when I've looked at it all, looked at the aberrations, looked at the dry eye, looked at all the things all those valid things that have been mentioned, and I go through it. Yeah, you don't have a dry eye, congratulations. Yeah, you don't have any coma, after your laser eye surgery, that's really good, and so on. And then I make the choice. But they've already had a lot of the discussion. But managing expectations, if they come in, if they're a chief executive type, and they have a green fountain pen and write in green ink, I'm not going to put a trifocal in that person because they're crazy. They'll drive me mad. So it's back to personality types. It's making your choice of patients. But yes, it does take time, but we have staff that do it. And the ones that take me too long, I probably won't do. And I'll put in an increased range of focus lens instead. Not of the types that you use. It's a different sort. But I'm not going to mention it because I work as a consultant for the company.
Well, I have Dr. Muhammad Husni. I think he would like just to comment on what we've been discussing. Please. Yes. Put it on, please.
He's got a wireless. Are you going to dance for us as well?
So basically, I know there's no a common consensus about using premium intraocular lenses or trifocal intraocular lenses in patients who had previous refractive surgery. But in my practice, I've never found that this is a contraindication at all. The main contraindication of implanting a trifocal intraocular lens, in my opinion, is an irregular cornea. So if you do have a LASIK procedure that has been done years and years ago, and the cornea has a very small optical zone, decentration, whatever, then definitely you will have a bad result. But I always say I'm actually on the opposite side of the spectrum. In patients that had decent, good refractive surgery, myopic refractive surgery, I think the only thing that we are all afraid of is hyperopic surprises. So if you do have hyperopic surprise when you pop in a monofocal intraocular lens, the patient will be definitely miserable. And mind you, this is a patient that 10 years ago did refractive surgery to get rid of his glasses. Now he's needing glasses for each and every distance. But if you implant a trifocal intraocular lens in this very same patient and you end up with a hyperopic surprise, which is, I know, not common nowadays, this is actually a safety net, so he'll be using his intermediate distance for far. So this will be a much happier patient. In my practice, I see patients who are unhappy after trifocals, if they had previous refractive surgery, are always patients that have irregular corneas. Okay? So if you have a very good tomography, a very good tear film, even if the patient did refractive surgery for a -9 back in the day, I would go on and give him a trifocal intraocular lens. Now, this is number one. Number two, along the years, we have been taught again and again and again by KOLs on podia that angle kappa is the holy grail that you... Actually, I've been seeing patients recently, not recently, actually over the past like couple of years, with high angle kappa that have implanted a trifocal intraocular lenses, but not by me necessarily, and are very happy and satisfied. And I see patients who are not satisfied and are complaining, and they come to me, and when I do them the eye trace, the angle kappa is very good. Actually, it's in the good range. And there are many studies now, I think I'm aware of 4, that report difference in angle kappa before and post-operatively. So you have different, values of angle kappa. So in my opinion, I run by the same schools. I mean, whatever Dr. Dai is saying is music to my ears, because this is actually what I believe, is that trifocal intraocular lenses are suitable for patients that had decent refractive surgery back in the day.
Stating that multifocal are not contraindicated in post-refractive surgery, but there are no guidelines, no consensus and guidelines what to do when. So people are looking at angle kappa, angle alpha, looking at preoperative, because what everybody is eager to learn is when not to do this. Yeah. So till today, we do not have the answer. And as you just mentioned, you have patients who have perfect angle kappa, they complain. You have patients who are off in their angle kappa, and they are not doing well. So what does that tells us? That tells us that we don't know when to and when not to.
Yeah, so my final comment, Ahmed, is that the current consensus among, let's say, like 95% of ophthalmologists all over the world, that if a patient did refractive surgery, he should not be a candidate for a premium IOL. And this is something that has never been written in stone, and the indications and contraindications are still on the boil. And we should not, be promoting these sort of rules. At least this is my opinion.
I agree, and this is where I started. I think what we are trying to bring here is more controversy than agreement. One, we don't all agree on the classification of the IOLs. We agree on this? Dr. Dresmer, what do you think? Do you think there is consensus? Do we really agree on that, like you said, written in stone?
Yeah, well, this I'm fully with Gerard. So this classification we are used to use right now, even my talks I put it because I didn't want to cause confusion, is something we could not, does not describe how the IOL really works. So they just use terms and put all their technology inside this term, and did not really know what kind of IOL it really is. So I can remember, because you mentioned this M+ IOL, I think. It was a multifocal IOL at former days. Then it turned to EDOF IOL. So it's ridiculous, actually. Yeah.
First of all, I apologize for my voice. I just lost it yesterday. No, it's okay. I think I totally agree with you. I think that the current classification is not clinically oriented. It's only commercially oriented. And you confirm this when you actually try to ask the manufacturer, okay, can you tell me exactly how your IOL works? Nobody tells you. They tell you, no, this is an EDOF, this is trifocal. Well, it's clear with the trifocals, obviously, but with the EDOF lenses right now, nobody tells you exactly how these so-called EDOF lenses works. And most of them, when you start like looking at the profiles and everything, you realize that they are not EDOF, they are just modified, let's quote unquote, multifocals or diffractive or refractive. So first of all, I agree with Dr. Chirag that we don't have a true EDOF lens yet. Maybe the ones with the pinhole, maybe.
I will take your permission, we will just move. We have
My plea is to, if you support what I've said, please use it in your presentations, in your titles, in your discussions. Please use this classification, breaking it down into three components. And that way, we all know what each other's talking about, and we can move this forward. It's time that doctors took the lead and not the manufacturers. We have to take the lead. We're the ones that talk to patients, not the manufacturers. Thank you.
It's me. So the final question for Dr. Daya. Dr. Daya, Shiraz, hello. The mysterious EDOF lens, is it the LuxSmart?
Sorry?
The mysterious EDOF lens, is it the LuxSmart?
Yeah.
Okay. I thought so.
No, it's not. No.
What you're using?
I've used it twice and I hated it.
Okay.
It didn't work for me.
Oh, really? The LuxSmart?
No, I mean, the problem is it is an EDOF lens in that it stretches the corner of stern, but patients don't see crisp.
Okay.
They don't have crisp vision. That's what
Dr.
they complain
Mohammed, you may take the stand.
about. No, eyes are pure.